TopMedTalk.
All right. Well, welcome to TopMedTalk. I'm Desiree Chappell, and we are at the Association of Anesthetists Winter Scientific Meeting here in beautiful central London. Monty, Mythen, is our editor-in-chief, and he is my partner in crime. Monty, how are you?
I'm on great form.
Yeah?
Great form.
Things going well? We've had a great meeting so far.
Okay, so I think we're going to get a chance to get out later on and have a look around. It's not so it's wonderful in here, but we're right on top of Westminster Abbey, right on top of the what we call the Houses of Parliament, the Palace of Westminster. I think you're going to get a little tour at the back end of the day.
I hope so. I tell the story we were here at ICS.
The good news is it's going to rain, so it's going to be
perfect London weather. Well, we were at ICS last year, and we literally looked at the Abbey for 3 days straight, and I never walked in, so... Hopefully we're
but you know what time it closes now.
Yeah, 3:30. Got it. Well, we have seen some friends of ours here at the Association of Anesthetists meeting, and we've run into Professor Henrik Kehlet, which is a friend of the TopMed family. Hi, how are you doing, Henrik?
I'm doing fine.
Yeah?
I wish I could be a tourist too, because I came last evening at 7 o'clock and went directly for dinner, and then I walked here. I have to escape.
You have to go out. Well, the Abbey closes at 3:30, so if you want to go...
Henrik, they're working you hard.
Yeah.
You've got 3 lectures, is it? Or
Two.
Two lectures.
Which is one I think you've just done about steroids, which we'll come back to in a moment. And there's a very tantalising title about enhanced recovery, implying the fact that it's a great idea but not necessarily getting done. Is that right? What's it called?
Yeah, the title was Good from Afar, but Far from Good. Question mark.
Question.
I'm sure we'll be brought back to that by Desiree shortly.
Yeah, definitely. Well, Henrik, we have a friend of yours, Dr. Nick Scott. Hi, Nick. How are you doing?
Hi. Good to meet you.
Good.
Yeah, I'm Nick Scott. I have spent the last 6 years working as the Vice Chairman in the Department of Anesthesia in Qatar, and I was formerly the head of the Department of Anesthesia in the Golden Jubilee in Clydebank in Scotland. And my main interests, having been Henrik's boy for a year, many years ago as his research fellow, I have very similar interests, and I've tried to take them with me around the world. But my main interests are in regional anaesthesia, and I'm currently working with B. Braun to try and standardise some of the courses that they run in regional anaesthesia.
Oh, very, very interesting.
And in the UK, you're one of the early proponents of enhanced recovery principles, I think.
That's right. We introduced it from the orthopaedic perspective into our hospital in the Jubilee in 2007. And then it quickly caught on everywhere else, and I led a Scottish Government working party to spread it out over the whole of Scotland.
So you're part of the solution, but also part of the problem, if I may suggest. because
Being Scottish.
Well, it's also that your results were just so fantastic that promoted this kind of A, I don't believe it.
Yeah.
B, we're all a bit jealous, so we're going to diss it, if you sort of.
Yeah.
C, it sounds hard, we'll never get round to doing that. But the people who have tried to replicate, I mean, they have fantastic results. I mean, you're down to pretty much day case joint replacements.
Well, that's right. And there's still a lot of work to do, as Henrik is saying. So the hospital in Glasgow is now effectively a clinical factory, doing over 3,000 joints a year. And I think it's about 25-30% of the Scottish total. So we have had very good results, but we mustn't be complacent.
Do you do is day case worth it? Is it worth it, day case, or 24-hour stay?
We have been superseded by Dundee. They did the first day case hip in Scotland, I gather, last year. So that's what I'm saying. We must never rest on our laurels. There's always work to do. But we're down to 2 days, and we're getting it.
It's a dangerous thing because because of the success of enhanced recovery, we have these cowboy surgeons, as I call them, who push too much.
Yes.
Yeah. And we have done in our multi-center work, 15% of Danish hip and knee can be done as an outpatient.
Yes.
Yeah, that's it. But that's not the question. The question is, should we do it? And there's some just published in BMJ Open from Stavros in Hospital for Special Surgery. They surveyed all the US data. suggesting that there were more complications with those who were done on an outpatient basis. I don't know if you have seen it. We have to be careful. It's all about safety and recovery. It's not about speed.
So allowing the patients to go home when they're ready to go home.
Personally, if I was going to have a hip replacement, God forbid it, I would stay.
Yeah.
I would stay until next morning.
Yes.
Yeah.
Maybe an extra day?
No.
Get home to the familiar environment as quickly as possible.
Yeah.
Well, Monty, we have been having this discussion the last couple days about predictions for 2020.
Yeah.
And what are some of the hot topics that we see? Monty, what were some of the ones we've seen?
So some of the hot topics was prehabilitation, for example, which has become quite a sexy word describing what we thought we were trying to do before, but maybe exercise programs are creeping in. Artificial intelligence and the use of closed or open loops is creeping in. Whether avoiding opioids, particularly in the USA, is in there. Other things have crept in. Oxygen, whether hyperoxia was a problem. The environment and sustainability has crept in.
Closed loop, open loop.
And you said that it should still be enhanced recovery because we've done a lot of talking, but not a lot of walking has got on.
So I've gotten a lot of flack for this over the last couple of days. That I say it's an oldie but goodie. I said, but as you say, we're not actually all doing it.
No.
And doing it the right way.
I'm not against prehabilitation, of course not. But I think we have to solve the post-op problem first.
Yes. Yeah.
Okay.
We have to solve it because patients still get sick. They are fatigued. They have a risk of complications.
Yes.
Mm-hmm.
And we have to go back to the pathophysiology of recovery. And then we go down to this inflammation, the inflammatory responses, the old-fashioned hormonal responses. Mm-hmm. It's not important anymore. We don't have negative nitrogen balance as we had many years ago. But the inflammatory response.
That's the key. That's the unifying component of it.
Exactly.
Mm. So the lecture that you gave today is kind of in that a little bit. So you can tell us about your lecture this morning?
Yeah, the background for it is really asking the question, why is the patient in the hospital? About 3-4 years ago, there was a fascinating study from Stanford by Bryce Godelier and co-workers. And they analyzed in detail immunological signatures after hip replacement. And the outcome were time to achieve mild pain, fatigue, and hip function. And they showed a fantastic correlation about the duration of recovery versus these inflammatory changes. So we took samples from our RCT, sent it to them with plus minus high dose steroids. And it's hopefully in press now in a very famous journal, showing in detail for the first time ever what happens with these immunological changes. And it lasted for up to 48 hours. And I think all this is fascinating. I reviewed the literature from elective surgery with high-dose steroids. A lot of questions, but it's not a safety issue. That is for sure. Efficacy is fantastic. Fantastic. I mean, it doesn't cost anything. It is simple. It is effective. It is safe. What more could you ask for? And you have a fantastic start of your enhanced recovery program regarding fatigue, pain, etc., across procedures.
Interesting, if I can, I'm going to interject myself.
Please.
Hi, Sol Aronson.
Sol Aronson. I'm so intrigued by the conversation.
Who is that mysterious voice?
Sol, that beautiful voice. Yeah. Sol Aronson, our U.S. anchor for TopMedTalk.
Thank you. Phenomenally interesting. Yeah. I'm going to, in my own vernacular, kind of paraphrase. I'm very much recently focused on determinants of readiness for surgery. If I may, what I'm hearing you say is readiness for discharge. And if we could have some kind of a biomarker or other phenotypic, if you will, marker to help us understand objectively when a patient is ready for discharge, that would be phenomenal. And then the whole science of teeing that patient up to have the perturbation of the surgical event itself, whatever that may be, is what it may be. But then we have to determine readiness for discharge. And we have to do that in an objective way to be scientific about this.
But this instrument they have in Stanford, it's a relatively small box, but I think it costs $6 million or something. They were able to predict preoperatively from blood samples those patients who were going to be hyper responders. So in the future, you can identify these patients pre-op, and then you can do your enriched trials in those patients where we should focus. It's just the same as pain trials. People have always just taken a bunch of patients and did an RCT. This is nonsense, because we have to separate patients into high pain responders versus low pain responders, pain sensitized patients, and then do RCTs in the different patient group, because maybe one analgesic is fantastic in one group, but all the other ones are just noise. They are easy to treat.
But I'm going to add to that. So the whole evolution of our thinking to be more personalized in our personalized delivery of medicine, notwithstanding nurture, nature, is it a genomic or a phenotypic variable? I would submit both. I would say that some of us are predisposed because of our DNA to be hyper or hypo responders, if you will. But superimposed on that are all the other modifiable comorbid medical conditions that we're subjected to because of the fact that we live in societies and cultures where we, are unhealthy because of the way we behave. And when we can modify modifiable, then of course we should. And I think there's a whole discussion about that. But what you're speaking to is the genotypic, the acquired, if you will, that we could better pre-select to.
But there's also the social aspect of it as well, because a lot of the original data on the stress response, as I was saying to Henrik just earlier on, averaged two groups instead of looking at individuals within the group and seeing if they came in at a high stress level before their operation, what was happening to their adrenal glands, cortisol synthesis pre, during and after, and were the high responders associated with poor outcomes or vice versa. We just don't know from that data. But this recent data is showing that whatever you do, bringing the stress response down does make a difference.
Brilliant, and I get it, and it's absolutely the right way to parse out, if you will, our analysis. My point is that within that high-risk predisposed population, there are going to be high-risk people and low-risk people, and within that low-risk predisposed population, there are going to be high-risk people and low-risk people. And we need to start to look at data more in a more sophisticated way.
Yeah, but we have to take it step by step because it's so complicated, as you say. But we have been too primitive in our RCTs, I think. But that's another debate.
For another time.
Big pragmatic trials versus...
Yeah, you have strong opinions on that, don't you?
Yes.
So I think there is some literature out there, Henrik, that if you look at some relatively simple markers like high sensitivity CRP measured preoperatively as a surrogate for your pre-existing level of ongoing inflammation, it is predictive of outcome in some way. Would that be an okay starting point, or is that too simplistic? Or
I don't know. I think it's a good idea.
Yeah.
But I'm not aware that people have done it.
Yeah, they have for high sensitivity CRP.
Yeah, we have it,
Yeah.
but I
They haven't done the stratification and the adaptive therapy intervention for the...
But then, it begins to be difficult. We have the assay.
Yeah.
We should be procedure specific.
Yes.
Then we take the patients, and then the care.
Yes.
should be
yes.
evidence-based.
Yes.
And then it begins to be difficult.
Yes.
So
because people are still not doing enhanced recovery.
Yeah.
They say, oh, we have a 75 or 78% compliance. Compliance with what?
With what? Yeah.
Think about the emergency trials published in The Lancet here from UK. Was it 30,000 patients? RCT? About 37 factors. There were only 3 factors post-op, and they were not well defined. Oh. We know from elective surgery that post-op care factors are the most important.
I'm going to throw another ingredient into the soup, if you will. In addition, in addition to the phenotypic or modifiable, acquired, if you will, comorbid, and the innate, if you will, DNA derivative genetic. There's also health socioeconomic variables that we have to consider. Mm-hmm. The education of a patient, their support system at home, if you're married or not, is probably more determinant of your recovery response than some of the other things that we would pretend to be able to manage. Yep. Health literacy is a untapped, if you will, component. So I think we have a lot of things to consider. I just think we should be aware of the gap of our abilities to pretend we know what we're doing. Yeah. Lots to learn.
Do you think, though, the post-op piece that I think a lot of people are missing, do you think that some of that we can start treating preoperatively with the pre-build that can affect the way that post-op is affected?
I have to be careful.
I think you said it all with a sigh.
I know, right?
Prehabilitation is a great idea. But all the data so far have not been impressive.
Because if you prehabilitate and then you don't get the right intraoperative or postoperative care,
you lose.
Yeah.
You lose what you achieved.
Yeah. Because you can actively produce complications in extremely fit and well people. Yeah. So it is a brilliant idea, but you need the trilogy, don't you?
Yeah. It reminds me about Gandhi. The story about Gandhi when he came to US. You know the story?
No, tell us, please.
He came down from the ladder from the ship, and there was a lot of journalists, and they said, "Oh, Mr. Gandhi, what do you think about U.S. civilization?"
I can see this one coming.
And he said, "I think it would be a good idea." And it's the same with prehabilitation, but definitely prehabilitation is right.
Yeah.
Yeah.
But in hip and knee replacement, all the RCTs have failed.
Yeah.
Yes.
Because the patients cannot do it.
Can't do it.
No.
Well, one question that I have, I don't know, Monty, you have any other questions?
I want to get from the steroids.
That's what I was heading back
tomorrow.
to.
Okay,
yeah.
well, I was going to say, what can we do tomorrow?
That's what I was just going to say. So do we all go back and we start using steroids on every patient?
As a clinical researcher, you can never force me to say so. You can never force me. I will say it's...
I need an answer.
Yeah, the answer is, it is so far so fascinating.
Yeah.
But there are still many questions. There are procedure-specific dosing questions. Mm-hmm. There is a question about repeat dosing. Mm. In certain operations.
What about pre-op dose, like a run up to surgery and dosing preoperative? Have they looked at that yet?
No. You have to start before the surgical injury, but not a day before. No.
Okay.
No.
But steroids modifying an inflammatory response has been demonstrated in the literature in animal and human models and ex vivo models for decades, and it always works.
Yes,
it's always the control intervention in such a way you think, well, don't look for new therapies, use that therapy. Mm. So now we're into the what dose, what patients, what response.
Yeah, but as I reviewed, we have so many data now, we are doing those response studies, etc. As I concluded, it is effective, it is simple, it is cheap, it is safe.
Yeah.
Can you name me some other interventions who fulfill these 4 things?
And the other thing, from the clinical perspective, I always, and again, it's a nice anecdote to say, but my senior orthopedic surgeon in the hospital in Glasgow was worried in 2009 because one of his colleagues told him, "Do you realise that Nick Scott is using steroid with his pre-meds?" And I faced a barrage. He came in with all his troops behind him and said, "Nick, is this true?"
Oh my God.
I said, "Yes, of course."
Right?
"Yes, of course it's true. Why are you worried?" And he said, "Because you haven't discussed it with me properly, and in fact we had talked about it, but he didn't want to admit it to his colleagues."
And then you went to work in Qatar.
But the whole point was that he said, "I'm worried about infection in my patients."
Yes.
And I said, "Well, that's a very valid thing to be concerned about. But if you're genuinely concerned, we've audited all our hips and knees for the last 5 years in the hospital.
Yes.
I suggest you go and compare your data against your colleagues' data, because I've been using steroids since 2004 in all your patients."
Well,
and we had the lowest hospital infection rate, post-op deep infection rate in Scotland at the time. And when he looked at his data, there were no difference between his data and everybody else's.
Wow. Well, sorry, Monty.
Is there any type of surgery at the moment where you could say with confidence that you think we should be giving a particular dose of best guess steroid at the moment that's higher than traditionally given? We're still not quite there?
I think hip and knee, definitely. Definitely. About 25 milligram of Dex at this time.
Right. That may go to a different place, but at the moment about 25.
Yeah.
Thank you.
Yeah.
And one-off dose?
Yes.
Okay.
Because we need more data on repeat dosing.
Do you think we would, because if we had a biomarker or a phenotypical change of some form that we could dose to, it would be a lot easier to work out the dose. You know, so sugar's too high, give more insulin. Sugar too low, give less insulin.
Yeah.
Is that there somewhere? You've got so many other things that drive the inflammation. Is the CRP up because of infection or no?
Well, when you talk about treating the problem of hyperglycemia, it's probably the wrong thing to do. You should acknowledge that it exists for a very transient period.
Oh, I know. I was saying that if we are trying to treat insulin deficit, for example, based on a high sugar, could we have the equivalent for a steroid dose? And what might it look like? And so it's going to be probably patient-based on profiling and phenotyping the patient. If they're pro-inflammatory to begin with, they have a very pro-inflammatory procedure.
I think this about glycemia is, again, a topic where there's a lot of misunderstanding.
Yeah.
Because there's so many data to show that if you take a large group of surgical patients and look at their glycemic response to surgery, those who have a very high response, they do worse.
Yes.
But that is, again, endogenous. That's patient procedure specific. Here we give a dose of steroids. That's an artificial modification of glucose homeostasis. And as we have published, it is short-lasting.
Yes.
But people mix it all up because they know that hyperglycemia in general may lead to more complications. This is different from an artificial induction of a transient hyperglycemic response.
Yeah. Well, I know that's not the question that you're asking, but if I can just interject one question. A lot of people hold the Dex doses for diabetic patients. Yeah. And I mean, where are you seeing that? Is that still appropriate? Do we just give it and just treat it the transient?
It is still appropriate to withhold it, at least in insulin-treated patients.
Yes. I was going to say everybody's diabetic now, though, but like a type 1 insulin. Yeah.
And one of the big problems with the non-insulin dependent diabetics is your nurses will see that they are diabetic and you've given the dose of dexamethasone and you're not worried about it personally.
Right.
But in recovery,
everybody else gets worried about it.
Everybody else gets worried. So you have to train your staff. So if the message is going out to everybody, out, in the broad anesthesiology public, the message is you have to train your colleagues as well. Yeah. Otherwise, you'll end up with someone who gets insulin when they don't actually need it.
I've had that in our programs that we've tried to start. That's been a key point for us to have to do. But Monty,
so I'm going to add 2 proposed topics to our top hot topics for 2020, and that's steroids.
Yes.
And I'm going to add the pathophysiology of recovery. We talked about this before, Henrik, and I know Sol's working on a series for perioperative medicine and a series of organ by organ. We have to go back to the pathophysiology. We have to go back to studies that explore the pathophysiology.
Exactly.
It's an honourable place to be. Good PhDs, discovery. And we've kind of gone to the mega trial and we've lost sight of the pathophysiology.
Exactly.
Yeah.
And we have to move away from guidelines, I think.
Yeah.
Research, pathophysiology. That's the way forward.
This is a random question that I don't expect there to be an answer to. So I'm going to put you on the spot. What's a marker? What do you believe could be a marker to determine readiness for a healthy recovery?
I think we still have to use the clinical markers. I mean, if you have a GI operation, it's that you are able to eat and function. You don't need a sophisticated biochemical thing. It's clinical. You have to be, if you have a hip and knee replacement, you have to be able to walk stairs. You have to be able to take your clothes on. You have to be able to go to the toilet. So we should focus on the clinical, procedure-specific, relevant discharge criteria. They are different from different operations.
From the standpoint of the effectiveness, if we get into the domain of what dose, how much, what type of steroid, to measure in an objective scientific way that impact, we need to develop better standard measures of that healthy recovery. And as simple as what you just described sounds, we probably don't objectively measure, track, and record that in a way that gives us the milieu to be scientific about asking the question, does the behavior matter?
Yeah, but now we are moving into a much more interesting topic. Because if we talk about discharge, it's simple. I mean, we know what discharge criteria should be. But what happens after discharge?
Functional recovery.
I will talk about it this afternoon.
That was a commercial for your lecture this afternoon, which is...
No, because that is a very difficult point. Because the government wants to support patient-reported outcomes. In hip and knee, there is now at least 8 studies showing a huge discrepancy between patient-reported outcomes and actual function capacity. And I will show you an example. It's terrible. And we have all these instruments now to assess activity, to assess sleep, hypoxemia for 2 weeks, etc., etc. And that should be used. That should be used.
That's interesting. Well, Henrik,
but enhanced recovery. What is that? That's why I have this title about good from afar, but far good. We have the hospital period. I think we have more or less solved that in elective. Then we have the real recovery, and that has been neglected. Think about pain. Think about subacute post-operative pain. We have talked a lot about chronic post-operative pain and acute post-operative pain. But the first 4 weeks, 6 weeks, this is the real important one.
So I'm going to invite you to steal this. But what you are really promoting is what you had already started, which is enhanced recovery after surgery, not enhanced discharge after surgery.
That's right.
And we've conflated the two, unfortunately.
Yeah.
Absolutely.
Yeah.
That's fantastic. That's a fantastic way to put it.
Yeah.
Well, looks like we have one more question here for Monty, but I think that's such an appropriate point because, one thing that I always say is that because people are getting out now could be the same day or 2 or 3 days where they were staying in the hospital for possibly weeks at a time, they don't have anyone helping them through that period at all. Yeah.
I just wanted to say congratulations on your award that you'll be receiving at this meeting, yet another award to celebrate the enormous contributions you've made to our field. Oh,
yeah, they say something. Yeah, but I haven't seen what it is.
Oh, it's in the public domain.
It's in the public domain. Yeah, I'm going to show you right now.
Yeah.
Oh.
Well, guess what? We're going to.
Well, I hope it's all right. I wrote something very nice. I hope something very nice about it.
He doesn't like surprises.
Oh, well.
I don't think it's a gold watch or anything. You'll need a truck to take it home.
Let's see here. It is the.
It is in the public domain.
Hold on. Oh. Professor Henrik Kehlet, honorary membership from the Association of Anesthetists.
Oh, there we go.
So I don't have an award to present you. He wrote this. He wrote the submission for you.
I cut and pasted from your CV.
Hopefully kind.
I'll send this to you, and then you can
send it to me.
Just act surprised whenever they present it.
It's in the public domain, isn't it?
It is. I mean, it's on the website.
Congratulations.
Thank you.
Like I said, just act surprised. You didn't hear it first on TopMedTalk.
Send it to me so I know how to behave.
The thought police are on us already.
I know. I think they're calling us out already. Well, Nick, thank you so much for joining the conversation with us. Yes, and Henrik, as usual, so wonderful to chat, and hopefully we'll see you again soon. Thanks again.
Hopefully. Thanks a lot. Take care.
Right. Cheers.
TopMedTalk.
It's Desiree Chappell here. Just a quick reminder, subscribe to TopMedTalk. We're a daily source of news and conversation focused on perioperative care. We bring you all the latest talk from all the major conferences in the perioperative space. We can also be found on Twitter, Facebook, LinkedIn, Instagram, and we now have a free mailing list with special offers and additional goodies for subscribers. Go check us out at topmedtalk.com. That's www.topmedtalk.com.